You're listening to Medscape's In Discussion series on Idiopathic Pulmonary Fibrosis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Jeff Swigris, Professor of Medicine in the Interstitial Lung Disease Program at National Jewish Health in Denver, Colorado. Dr. Swigris directs research centered on how patients live with and experience interstitial lung diseases, how to best assess that experience, and how quality of life may be improved for patients suffering from interstitial lung disease. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Welcome to Medscape in Discussion on the topic of idiopathic pulmonary fibrosis, or IPF. I'm Dr. Jeff Swigris, and today we'll be discussing antifibrotic therapy for patients with IPF. We're going to be tackling some questions such as, should every patient with IPF be on an antifibrotic? How do we make a decision about which antifibrotic to use? What happens if my patient progresses more than I would expect them to despite being on an antifibrotic? And finally, what are some key points we all need to know about acute exacerbations? And with me to dig into these questions is Dr. Adegunsoye Adegunsoye. Deji is an assistant professor in the Department of Medicine's section of Pulmonary and Critical Care Medicine at the University of Chicago. He is scientific director for the ILD program there at the University of Chicago's Medical Center in Chicago, Illinois. He is a real star in our field, a friend and colleague of mine, and I'm so happy to have him here. Deji, welcome.
Thanks. It's a pleasure to be here today.
Before we dig into all these interesting topics on antifibrotic therapy, tell me how you initially got interested in this field. What drew you to taking care of patients with IPF and doing research into this condition?
That's really an interesting story. When I was a second-year resident, I had a middle-aged patient who could not breathe. She had just been admitted to the hospital through the emergency department for profound shortness of breath. Despite this, when I walked into her room, she had friends visiting her and they were all playing bridge together. When I initially examined her, I heard bibasilar crackles, those Velcro-like sounds that we hear from the lungs on auscultation. And her saturation on room air at the time was in the mid-80s, despite receiving lots of supplemental oxygen. She could barely get out a complete sentence. She died within 72 hours before we were able to diagnose her, unfortunately. Her autopsy shortly afterwards confirmed she had pulmonary fibrosis. In Nigeria, where I'm originally from, the life expectancy is just about half of what it is here in the US. And it's remarkable that here in the US, when people get just to the point of being able to relax a little bit after working all their lives, that's when this terrible disease hits. I want to change that. I really do.
Isn't that true? That's the average age of patients with IPF is 65 to 67 years, and you're exactly right. We see these folks in clinic, and they've been working their whole lives, much like your patient, and they finally get to the point, oh, yes, I can retire. It's about that time when they notice, wow, I have shortness of breath. I can't do the things that I once did. And unfortunately, we end up making this diagnosis all too frequently in this age group. Thanks for sharing that with us. So let's move into our topic. Recently, the clinical practice guidelines for IPF and this new entity, progressive pulmonary fibrosis, were published. We're not going to spend any time today talking about progressive pulmonary fibrosis that is not IPF. We're going to focus our discussion on antifibrotics. But those guidelines did mention a few things about therapy in IPF, and specifically there were some recommendations by an expert panel that we should no longer use anti-acid therapy, proton pump inhibitors, targeting slowing progression of pulmonary fibrosis. Nor should we routinely use anti-reflux therapy with the intention to slow progression in IPF. The 2015 guidelines on antifibrotic therapies for IPF still hold. And that's where I'd like to begin our discussion now. So let's start with the very broad question, somewhat challenging. Should all patients with IPF be on an antifibrotic?
I like that you said it's somewhat challenging because it is. Many pulmonologists who care for patients with this disease will say yes, that all patients with IPF should be on an antifibrotic. I do think the jury is out on that, as the decision is much more nuanced. It's not exactly black and white. Every patient is different, and oftentimes they have a unique spectrum of comorbidities that influences the choice of pharmacotherapy in them. I do believe, however, that each patient with IPF should be provided with the available data on antifibrotic therapies. And that's because of the profound benefits of lung volume preservation that we see, while we also carefully consider the potential adverse events that could occur in the patient in question. I think that this should be done in a fully transparent fashion in terms that the patient can easily understand. And when all that is completed, then the patient should be offered the choice of starting antifibrotic therapy in a shared decision-making process. That's really been my approach to this question.
I think that's a great approach. I think you're right, Deji. I know we all have different philosophies of how we practice medicine, and I come from a family of teachers. And so my philosophy, and I know many other physicians, is educate. We need to educate our patients, or there is no way that we're going to be able to allow them to make informed decisions or to share in that decision-making with us. And what frustrates me often, and I'm sure you see patients like this, patients get referred and their practitioner, maybe it's a physician or a mid-level, has decided this patient should not be on antifibrotic therapy, and they don't even discuss the option with them. So I echo your sentiment. I think we need to be transparent. We educate our patients that, you know what? These therapies are approved. They may be right for you at this time. They may not, but it's important for patients to fully understand that they're out there and what's involved by taking them, both the potential benefits and the potential adverse effects.
That's exactly right.
So, okay. So you have a 65-year-old gentleman in your clinic. He has a usual interstitial pneumonia pattern of lung injury on a high-resolution CT scan. He has no known cause for this pulmonary fibrosis, former 20-pack year smoker 30 years ago. You diagnose him with idiopathic pulmonary fibrosis. We know that we have two potential drug therapies available to us, nintedanib and pirfenidone. And if we look at the trials, the confirmatory large phase 3 trials for those entities, the results are really generally overlapping. And it's a little frustrating for me that the pirfenidone trial, the longitudinal modeling of forced vital capacity, the mixed effects model, the model that we could use to actually compare apples to apples with nintedanib, was buried in the supplement. But if we look at mixed effects models from each of those trials, I think we would all agree that nintedanib and pirfenidone are equally beneficial, that on average, patients on antifibrotic therapy, be it nintedanib or pirfenidone, on average are going to lose 100, 115, 120 cc's of FVC over 52 weeks, and patients who are on placebo in either of those trials will lose roughly twice that. And so if we believe that these two drugs are essentially equally effective, how do you make a decision for that patient who's sitting in front of you? Should I be on nintedanib or should I be on pirfenidone, doc? What do you tell your patients, Deji?
So I was smiling to myself as you were stating the question, because that patient you described is the exact patient who walked into my clinic last Thursday. So first, let me add that I think it's a shame that we only have 2 FDA-approved therapies for this devastating disease. I really am encouraged by the tremendous amount of research that's currently ongoing on multiple fronts to change that. I think it's long overdue. Now, that being said, I completely agree with you that both antifibrotic therapies are effectively similar regarding their efficacy, with almost identical impact on reducing the lung function decline that we all too often see. I frequently, let the patient's lifestyle, their comorbidities, and ultimately their preference help guide me in that decision-making process. Both medications are pills that are associated with some degree of nausea and vomiting, as well as hepatic side effects or hepatic dysfunction. However, that being said, pirfenidone has been associated with photodermatitis, which is a form of skin rash that breaks out upon exposure to sunlight. And as such, patients who have a heavy preference for being outdoors or have an occupation or hobby profile that makes them want to stay more outdoors, they would often decline to use this medication for that reason. In contrast, nintedanib isn't marked by this. It has been linked to a more frequent occurrence of diarrhea as well as some elevation in bleeding risk. And as such, patients on full dose anticoagulation, especially those who are also receiving high-dose antiplatelet agents, they may not be the best candidates for nintedanib therapy. And so these profiles are often, let's help guide that decision-making process, because ultimately they influence the patient's quality of life as well.
Yeah, I tend to, certainly in my octogenarian, so my 80-year-old, if they're on systemic anticoagulation, I will still use nintedanib, but I tend to gravitate toward pirfenidone as a first choice in those patients. I think one of the messages that you mentioned is these drugs are equally effective. So you're not losing efficacy by choosing one over the other. And sometimes patients can tolerate one perfectly well while they can't tolerate the other. And that's a nice segue, actually, for our next question. We talked a little bit about that expected progression, 100, 120 cc decline in FVC over 52 weeks is the average that we saw from those large phase 3 confirmatory trials. So if that patient that you saw in clinic last week, you put them on whatever, let's say nintedanib, because they're always outside. He's working outside, loves to have his shirt off when he's working in the yard, and you're nervous about the photosensitivity rash with pirfenidone. You start him on nintedanib, and over the following year, he's declining. And it seems like every time he comes in, he's down 100 cc's, another 100 cc's at 6 months. And, at 9 months, he's down 300 cc's. Should you switch him to pirfenidone? Should we keep this patient on nintedanib? What's your typical approach, or what do you think about when you're confronted with that? And incidentally, we're confronted with that quite often.
Yes, exactly.
Aren't we, as practitioners? And so knowing that there's no right answer, I'd love to hear your general thinking and approach to that situation.
Yeah, I think that IPF is a chronic disease. And like many other chronic diseases that require long-term pharmacotherapy, the decision to switch or not to switch should be taken in context of the entire patient and their living circumstances. Rather than jumping to switching to the only other available antifibrotic we have that's FDA approved, I often will start with simple things. One, are they adherent to pharmacotherapy? Are there causes that we can address that might be making the patient less adherent to the current medications that he's taken? If they are adherent to medical therapy, then the next question I ask myself is there a new spectrum of comorbidities that could also impact their lung function? Simple things like acid reflux, which we call GERD, gastroesophageal reflux disease, can also impact lung function. Is there a new pneumonia, either bacterial or fungal, that they may have that we don't know, hasn't been as apparent as it should be, because they're going to be coughing and having shortness of breath either ways? Do they have new pulmonary hypertension, or do they even have sleep-disordered breathing disorders like OSA, obstructive sleep apnea? And should they now be on a CPAP device to help mitigate the effect of that? So after ruling out comorbidities, then I want to optimize what they've got. Have they been given the opportunity to participate in pulmonary rehabilitation? That can improve their exercise capacity and potentially also have some impact on lung function. Should we then start thinking about considering alternate pharmacotherapy? And this doesn't necessarily have to be antifibrotic therapy. It could be an immunomodulatory agent. Have they got evidence for additional inflammatory features on their CT scan? Or if they have a biopsy, do we see evidence for inflammatory changes that might steer us towards the direction of starting an immunomodulatory agent? Now, ultimately, if none of these are effective, none of these are beneficial, especially for those with continued progression, we really want to strongly consider referral for lung transplantation. Again, here, the key is to improve the quality of life of the patient, improve their survival outcomes as much as possible. And oftentimes, having these patients early within the radar of the transplant team is often a good idea.
Yeah, I think those are great points. We all get enamored of drug therapy and, we should switch drugs. take a step back, listen to your patient, figure out what's going on with them, make sure they're adherent to therapy, make sure that there's not something new going on that could be driving lung function decline. And then at the end of the day, you might have a discussion about switching therapy, but recognizing there's no right answer. And one of the things that we struggle with is when we put a patient on an antifibrotic, we have this expectation based on average results from trials, but taking those data and applying it to an individual patient is impossible and probably not realistic and maybe bordering on inappropriate. What we'll never know is, okay, they had 300 cc's decline over 9 months on nintedanib. And if they hadn't been on nintedanib, would they have declined, 1.5 liters? That's something that's unknowable. Equally unknowable is their effect on pirfenidone going to be better than it was on nintedanib? Unknown. Are they even going to tolerate pirfenidone? So I think, as Deji mentioned, take a step back, look at your patient, make sure that they've been adherent, look for additional things that could be going on that drive lung function decline, and then have a transparent, realistic discussion. Hey, here's what we know. Here's what we don't know. We could switch or we could not switch. How do we feel about that at the time? Unfortunately, there's really no better answer than that. Do you have a particular dosing strategy with pirfenidone? And I'm not trying to be coy. I just wonder, do you just do a standard 3 pills at a time dosing, or do you have your own regimen that you like to use?
Pirfenidone is FDA approved for use as 801 milligrams by mouth thrice daily. And typically it comes in 3 pills of 267 milligrams each. I tend to start low and go slow. And by that, I mean a slow dose increase over a 14-day period. So something like 1 tablet thrice daily for 5 days, then 2 tablets thrice daily for 5 days, and then 3 tablets thrice daily for another 5 days. I typically recommend that it be taken with food. And for patients with nausea or acid reflux, I recommend the use of antiemetic agents and antacids respectively for those conditions. In all patients receiving pirfenidone, I advocate for sun avoidance to mitigate the risk of photodermatitis.
Yeah. Let's shift gears to our final topic today and talk about acute exacerbations, these acute declines for unknown reason. What I describe to my patients is the disease behaving badly. Patients will often ask, well, what did I do? What could I have done differently? As far as we know, nothing. So just take us through, what are some key points, maybe 2 key points about acute exacerbations that you'd like our audience to take away from this discussion today?
Yeah, great question. So first, what is an acute exacerbation, right? So to put it in layman's terms, these are simply an acute respiratory deterioration in the clinical state of patients who have ILDs, such as IPF, and they typically last for about a month or less in duration. Now, every year, about 5 to 15% of patients with IPF will develop this worsening of their baseline disease state. And when you look at the CAT scans, the chest CTs of these patients, they do have bilateral ground glass opacity that are not primarily from heart failure. In these patients, we will also typically exclude other extraparenchymal causes such as pulmonary embolism, pleural effusion, and pneumothorax, which can also lead to that, shortness of breath worsening that we characteristically see in IPF. Now, it's unique because unlike IPF, which for susceptibility has been linked to genetic causes or factors, environmental factors, and behavioral factors, IPF acute exacerbations are often linked to environmental triggers like infection, drug toxicity, aspiration that we talked about moments ago, even post-operative stress. And then in contrast to the regular IPF clinical course, which typically takes years to get to end-stage fibrosis, acute exacerbations take days to weeks, and the short-term mortality is typically about 40 to 50%, which is really high. And so preventing these known triggers appears to be quite important to reducing the risk for acute exacerbations.
Out here in Colorado, we have wildfires, and wildfires are typically, they're west of Denver, but you can smell the smoke here in Denver. And we know that the air quality in Denver during wildfire season and other times is not great. But the air quality west of here in the areas affected by wildfires is really poor. And last year, we saw quite a few acute exacerbations from patients who were exposed to wildfire smoke. And I don't mean that they were right in the heart of the wildfire, but just the poor air quality as a result of the wildfires promoted acute exacerbation. Do you have a standard approach to therapy, recognizing that we know that there's nothing that's been proved absolutely beneficial here? What's your typical approach?
Yeah, my typical approach is to find the cause and then try to fix it. Not all the causes are eminently fixable. The ones that you do find should be addressed appropriately and in a timely fashion. And so oftentimes when patients come with acute exacerbations, they're looking for the things I mentioned. Is there infection that might benefit from antibiotic therapy or antimicrobial therapy if it's antifungal? Do they have a new aspiration event that might require addressing acid reflux, either laparoscopically or, with medications or other lifestyle modifications? Have they been exposed to other factors? So things like venous thromboembolic disorder, pulmonary embolism might also be a factor that causes IPF exacerbations to be triggered. So I look for a cause in these patients and try to address them as early as possible. And for antimicrobial therapy, I don't often wait to get a bug before we start to treat. We start with empiric broad spectrum coverage, get all our samples, and then narrow down based on what comes back. Again, because you're trying to get ahead of the time that you've lost in these individuals.
Are you typically giving steroids as well in combination with antimicrobials?
I think steroids are a big black box because we don't know exactly what value they bring. And there have been studies, retrospective small observational studies, that suggest they may not give the value that we thought they did. And so I'm a little bit more cautious, even though I still from time to time give these patients high dose steroids, but it's a very short burst of steroids, no prolonged duration, and take it away as soon as you can because we know the harm that it brings in patients with IPF on a chronic basis.
Yeah. I think a key message is that's a really challenging clinical scenario, acute exacerbations, regardless of the clinical circumstance. Okay, give me your 3 big points from this discussion today. Just 3 bullets that you want our audience to take away.
For me, the first and probably the most important bullet point is that not all cough is COPD and not all shortness of breath is heart failure. A substantial proportion of patients who have these symptoms have pulmonary fibrosis. And in them, time is of the essence. The second one is early intervention is key, right? And so as soon as we can, want to recognize this condition early. And it's absolutely key to intervene early to improve quality of life and survival outcomes across board.
In the case of IPF, have that discussion about whether antifibrotic therapy is appropriate for them at that point in time.
Absolutely. Intervene as soon as you can with pharmacotherapy where appropriate and with other adjunctive therapy where you need to as well. And then the third bullet point is, I would say, hope is on the horizon. We're seeing a ton of research endeavors panning out, and there is hope coming real fast, real soon. So hang in there.
That's great. And I love ending on the hopeful. Thank you, Deji.
Well, thank you, Swig, for having me today. It's been absolutely delightful to participate in this session.
With that, we're going to wrap up. Thank you so much for listening to this conversation on idiopathic pulmonary fibrosis with our guest, Dr. Adegunsoye Adegunsoye. There's much more ahead in the coming episodes, so be sure to check out the Medscape mobile app and share, save, and subscribe if you enjoyed this episode. I'm Dr. Jeff Swigris for Medscape in Discussion.
Thanks for listening to Medscape's In Discussion Idiopathic Pulmonary Fibrosis podcast series with our host, Dr. Jeff Swigris. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on idiopathic pulmonary fibrosis.